Uh, Thank you everyone for joining. Today we have another lecture of online course of Principles of Surgery. And today's topic is Management of Shock. And today we have Dr. Geoffrey Anderson, a trauma surgeon at the Brigham and Women's Hospital and assistant professor of surgery at Harvard Medical School. Dr. Anderson is deeply involved in research and is the director of Tiger Lab and part of the faculty at the Center for Surgery and Public Health and program in global surgery and social change. He previously served in Air Force Special Operations as a flight surgeon and was deployed several times to Iraq and Afghanistan. Dr. Anderson was among the first American surgeons who went to Ukraine at the beginning of the full-scale invasion to teach Ukrainian physicians and other medical workers to ATLS course, Advanced Trauma Life Support course. So thank you very much, Dr. Anderson, for agreeing to give this lecture for our Ukrainian colleagues. We're all happy to have you today.
Thank you, Ali, for that introduction. Good to see you all. I'm going to be talking today about the topic of shock, which is a really big topic. I'm going to share my screen now. Give me 1 second. Okay. All right. So I'm going to be talking about shock. Huge topic. Lots to go over. Just an overview. I'm going to talk just about the definition of shock. We'll go over the types of shock that exist, how you evaluate and treat a patient who's in shock. It's such a big topic with many different types of shock and many different ways of approaching it. I'm going to focus mostly on trauma and hemorrhagic shock. I'm a trauma surgeon, so that's my bias. It's also, I think, one of the most important to talk about, but we will talk about, or at least touch briefly on some of the other types. If you have questions, I'm happy to answer them, either as we go or at the end, whatever makes more sense. But just to start off, we should get on the same page as what we're discussing. So the term shock, we often think of it as a patient who's hypotensive, and that is true. That's a big feature of shock, but it's not synonymous with hypotension. Basically, shock is blood flow that's inadequate to meet the cellular demands of the body. You get organ hypoperfusion and dysfunction, organ failure. So whenever there's a mismatch between supply and demand of that oxygen delivery, you're talking about a patient who's in shock. There's no set cardiac output. There's no set urine output, central venous pressure, blood pressure, none of these things. There's no like set numbers that I can give you. There's some general ones that we'll talk about that help guide you, but it's more about putting the patient together in a bigger picture. So inadequate tissue perfusion is the kind of textbook definition of shock. And when you're talking about practically, it is helpful to have some numbers in your head. So we usually talk about low blood pressure, so a MAP, a mean arterial pressure of less than 65. And then you combine that with evidence of end-organ perfusion, of malperfusion. So it's not just enough to have a hypotensive patient. There's some patients who do quite well. Patients who are in liver failure or cirrhosis often walk around with MAPs of 55 or 60 and have no problems at all other than their ongoing cirrhosis. And then there's other patients who you shoot for a MAP of 65 and their urine output drops off and they go into renal failure because they need a higher perfusion pressure. So you need to bring all those other things into consideration when you're talking about diagnosing and treating shock. But the things you're looking for, that hypotension and those other things that you're looking for are evidence of end organ damage. So that can be the brain, and you get altered mental status, confusion, coma. It can be the lungs, and you get hypoxia and tachypnea. It can be the cardiovascular system. In addition to the low blood pressure, you get tachycardia, chest pain, weakened pulses. You can see it in the lab sometimes with elevated troponins, elevated lactate, elevated creatinine, or the urine output drops off. And you can sometimes see it in the skin. You see modeling of the skin and ischemia of the digits, the kind of classic fingers and toes of patients in prolonged shock, as pictured there. So that's the definition. And the time is of the essence in shock. Time is tissue, as we'll say sometimes. So it's critical to identify patients who are in shock and then rapidly start treatment. You often are starting treatment before you even have fully elucidated what the cause is. When you see somebody come in, for instance, to emergency with undifferentiated hypotension and they're doing poorly, you're often are starting resuscitation right away, and at the same time you're investigating for the causes. But it is important to ultimately get to the causes, because what the underlying cause is going to dictate what you do. If it's sepsis, you're giving antibiotics and you're getting source control. If it's hemorrhage, you've got to stop the bleeding and give the patient blood back. And if it's cardiogenic, maybe you don't want to give a ton of fluids because they might be volume overloaded. You're doing a lot of supportive care of the heart. So the ultimate cause does matter. I thought I would just kind of illustrate this a little bit with a case study. So imagine you're in the emergency and you've got a 23-year-old man, gunshot wound to the leg. He arrives in the emergency department. You see one hole in the anterior thigh with pulsatile bleeding. He gets hooked up to the monitor and his heart rate's racing. He's hypotensive and he's not satting well. So this is a patient who pretty darn quickly you can tell is in shock. And, you know, this one isn't a diagnostic dilemma, right? He's got a hole, spurting blood. This is a patient who's in hemorrhagic shock. Immediately in the emergency department, you can do two things to immediately address this patient. We're going to talk about going through the ABCs of the ATLS teaches, Advanced Trauma Life Support, but you can immediately stop the bleeding, either direct pressure or throw on a tourniquet, and then get blood going for that patient. So this is the kind of patients we're talking about, in extremis with some sort of underlying cause for their shock. Okay, so categories. I want you to keep in mind these four broad categories of shock. These are the four kind of categories we'll be talking about for the next hour. And each of these categories will have subtypes, which we'll go into in particular. So hypovolemic, distributive, cardiogenic, and obstructive shock. Those are your four broad categories. And all the types of shock will fall into one of those four. When you're trying to kind of figure out what's going on with the patient, sometimes it's helpful to have a little bit of this in, this chart in mind. We have the four categories of shock there, and then some of the characteristics that you'll see pretty quickly on the patient. So everybody's going to have a low MAP. All these patients will be hypotensive in shock, and almost all of them will have a low cardiac output. But the distributed patients like septic patients may even have a high cardiac output, at least initially, or it can be kind of normal and then ultimately low. Systemic vascular resistance is usually jacked up. The patient's blood pressure is low, so the body's doing everything it can to peripherally squeeze to increase the peripheral vascular resistance, to decrease the volume of distribution. But in distributive shock, the SVR is actually low. That's the whole cause of distributive shock. Volume status, often low, hypovolemic, distributive. But in obstructive shock, it doesn't really matter. The volume status can be anything, and you can get obstructive shock. And in cardiogenic shock, it might be high. So these are some of the physiologic findings you're going to see in these patients. And they help us to, help us to kind of differentiate. So again, here's your four categories, but then I've listed in this table some of the different specific types. So under the distributive shock, we've got septic. That's usually from kind of capillary leak. Then there's anaphylactic and neurogenic. You lose vascular tone. Hypovolemic shock, that one's pretty easy to understand. You just don't have enough fluid going through the body. That's either because you're bleeding in hemorrhagic shock, or you're losing other types of fluid in the other types of non-hemorrhagic hypovolemic shock, like GI losses, burns. Cardiogenic shock is usually due to some sort of intrinsic heart disease, so either an injury to the myocardium from like ischemia, a conduction system issue and arrhythmias, or a valvular issue. And then finally, obstructive shock. We typically think about things like cardiac tamponade, massive PE, tension pneumothorax, even abdominal compartment syndrome can give you a obstructive shock. So let's go through each of these in turn, with a special consideration, like I said, for the hemorrhagic shock as one that's close to my heart, and I think one of the most important ones to know about. So the most common type of shock is hypovolemic shock. It's caused by a decreasing blood volume, and this can be due, again, to hemorrhage, probably the most common, but then also just dehydration and burns will cause hypovolemic shock. Low heart rate, so low MAP, low cardiac output, low volume, and then an increased systemic vascular resistance. So hypovolemic shock, hemorrhagic, that's what we're going to start with. This is your typical patient in trauma. It can also happen with GI bleeds, but trauma is the most common scenario. It's one that I see every day. And And when you do see a trauma patient who's hypotensive, there can be other causes of hypotension in a trauma patient, but the most common cause and the thing that you have to rule out first is hemorrhagic shock. So hemorrhagic shock, so a patient in shock in trauma is hemorrhagic until proven otherwise. I'll touch just briefly on this. When you see that trauma patient come into the emergency department and you're trying to figure out how far into the shock you are, there are classes of shock that we typically talk about. Class 1, 2, 3, 4 hemorrhagic shock. That's based on how much blood volume you've lost. I'll point out that class 1 hemorrhagic shock, you can lose up to 750 mLs or 15% of your whole blood volume, and nothing really changes. You'll have a normal heart rate, normal blood pressure. You may see a slight narrowing of the pulse pressure. So that's one of the first signs that you see, a narrowing of the pulse pressure. So the systolic and diastolic blood pressures will get closer together. That's usually because of that increased vascular tone, raising the diastolic blood pressure. Respiratory rate's going to be near normal. Urine output's going to be normal. Patient's going to be mentally normal. So you can lose up to 750 mLs and you won't even notice it in your patient. So you have to be careful of that because pretty quickly things start to go down. So once you've lost 1.5 liters, that's when you're going to start to see the tachycardia. Blood pressure is still going to hang on. Pulse pressure is going to be decreased. They're going to be breathing a little faster. Maybe the urine output starts to drop off a little bit, but usually you don't even notice that yet. And then in class 3, that's when things are really starting to drop off the cliff. That's when so their patients are going to lose up to 2 liters of blood before you even notice a decrease in their blood pressure. And this is the scary thing about trauma patients is that they'll compensate, especially the young, healthy victims of, penetrating violence or bad, motor vehicle crashes. They'll maintain their blood pressure forever until they drop off a cliff. So stage 3 hemorrhagic shock, you lose up to 2 liters of blood. That's when you're going to be very tachycardic. Blood pressure is going to be decreased. Your respiratory rate's going to start to skyrocket. They're going to start to get confused. And then finally, stage 4, that's when the patient's starting to die. And that's over 2 liters of blood loss. So how do we approach these patients who are in hemorrhagic shock? The thing that we talk about in advanced trauma life support class is the ABCs. So, and this is a good way to, approach any patient in extremis, but especially in trauma. So airway is number 1, that's A. You examine the airway, and if it's protected, great. If it's not protected, then you need to establish a definitive airway. That's a different class. Assist the breathing if needed. And then C, that's the big part for shock here. Establish large bore IVs, look for signs of shock, stop the bleeding, and begin your resuscitation. That all should happen kind of all at the same time. And then there's the D, disability, that's checking for pupils, looking at the extremities and calculating a GCS. Then you want to fully expose the patient. And that's so taking off all their clothes so you can see any areas of bleeding. But then once all the clothes are off, hypothermia is going to set in pretty quick. And you want to avoid that because that's just going to make the bleeding worse. So you want to immediately start putting on the warm blanket or something else to prevent hypothermia. So I will say we use the ABCs a lot in the civilian world. The military has taken a slightly different take on the ABCs. They've changed the order to CAB, or because it's the military, they use the term March. But what that's become from analyzing data from the battlefield. And what we saw in Iraq and Afghanistan is the #1 cause that patients die that's preventable. So not some sort of devastating brain injury that you can't recover from. The #1 preventable cause is massive hemorrhage. So we changed the order from ABC to CAB or March. So you do a quick sweep. You take off all the clothes and you do a quick sweep for massive hemorrhage. And any massive hemorrhage that you can stop with a tourniquet or direct pressure, you immediately intervene upon that. And then you continue on your normal pathway of airway, breathing, go back to circulation. And then you're doing your disability and preventing hypothermia. So we use the term March, just a slight reorientation in kind of the battlefield setting. So you're evaluating the patient. You want your overall impression. Are they stable or unstable? That's going to dictate how quickly you go through this algorithm. Rapid sweep for massive hemorrhage. Then you go into your primary survey, your ABCs, and get your vital signs. And then, especially for that unstable patient, you want to triage cavities. And what I mean by triage cavities is in a patient who's bleeding to death, you want to rapidly identify where the patient is bleeding to death. Because if someone's in shock, hemorrhagic shock, you need to stop that bleeding. But in order to stop the bleeding, if that patient needs to go right to the operating theater, you need to know, once you get to the operating room, what are you going to do? And so it's important to keep in mind that in trauma, there's 5 different cavities or blood or body spaces that a person can bleed to death. Chest, that's kind of an obvious one. You can bleed to death in your chest. The abdomen definitely has enough space where you can bleed to death. The pelvis as well, bad pelvic fractures can lead to kind of a extraperitoneal or retroperitoneal hemorrhage that can, where a patient can exsanguinate. The extremities can do this too. You usually have to have like more than one. So usually bilateral thighs is the classic kind of extremity cavity where you can bleed to death. And then we say the last cavity is the street, which is to say externally. The patient can lose enough blood just into the environment that they bleed to death. The one time I see this is that is I think worth specific mention is scalp lacerations. It's easy to overlook a scalp lac because it's just, you know, a simple laceration in the scalp. It doesn't look severe. Maybe it's oozing, but don't underestimate a scalp laceration. Put some staples in there or wrap it tightly right away, because it's easy over the course of an hour of kind of doing a primary and secondary survey on a patient and trying to get them to imaging that they lose multiple units of blood that kind of slowly, continuously bleeding from that scalp laceration. So don't underestimate scalp lacs. So how do we triage? If those are the 5 places patients can bleed to death, and we need to get an unstable patient rapidly to the operating theater, and then when we get there, we need to know which of these cavities to open. Well, you got to triage them. You got to find a way of evaluating which cavity maybe has the bleeding, is hiding the bleeding. So a chest x-ray or an ultrasound. If you see a massive hemothorax, then you're going to want to put a chest tube. And then if it's a lot of blood, then you're going to deal with that. The abdomen, you're going to do your FAST exam. So an ultrasound of the abdomen, or even a diagnostic peritoneal aspirate, where you make a small incision above the umbilicus, place like a central venous catheter in there and aspirate with a syringe to see if there's blood in the abdominal cavity. That's kind of an old school way of doing it if you don't have FAST available, or if the FAST doesn't give you good windows. The pelvic x-ray, if you see a big open book pelvic fracture, that can definitely be the source of massive hemorrhage. So you put an abdominal binder on, and then you're making a plan to deal with extraperitoneal hemorrhage from pelvic fractures. It can be challenging. Bilateral thighs, your exam is going to tell you if they're bleeding massively into their thighs. The thighs are going to be huge. And you can get an x-ray to confirm if there's big fractures that may have lacerated an important artery in the thigh. You can deal with the tourniquet. You can use a tourniquet to deal with. And then finally, the street. So that's going to be your exam, looking for external signs of bleeding, especially that scalp lac. So you've identified that patient who's in hemorrhagic shock. You've done it very rapidly in your primary survey. You've kind of gotten some quick imaging. To treat it, it's really not a surprise. There's no kind of mystery here. The patient's bleeding to death. You need to stop the bleeding and give them blood back. So stopping the bleeding can be direct pressure, tourniquet, or if it's something in the trunk of the body, that's the operating room you have to go to. You want to give them blood back. We'll talk more about how you give them blood here in a second. You want to avoid the lethal triad of trauma. This is a triad that we see that can kind of be a positive feedback loop that leads to death. And these patients are bleeding to death, so that under resuscitation leads to acidosis. The acidosis causes the enzymes to work and the platelets to work poorly, which leads to a coagulopathy. Plus the bleeding adds to the coagulopathy because you're losing platelets and plasma that have the clotting factors in it. A patient who's been exposed to the environment and is losing blood cannot maintain their core body temperature, so they get hypothermic. That causes worsening acidosis, worsening coagulopathy, and you get this death spiral. So be wary of this patient who has this lethal triad. We'll talk about a little bit more about the lethal triad in a second. And I'll also just mention this topic of permissive hypotension. This is a strategy that I'll talk about now. It's a concept that's more relevant for a patient who has truncal bleeding, so bleeding in their chest or abdomen or pelvis, that it's how to treat them before you get to definitive control. So that patient needs to go to the operating room to stop the bleeding. Before you get to the operating room, you're not shooting for normal blood pressures, because if you jack up their blood pressure too high, before you get definitive control, then you may have a too much pressure for whatever nascent clot they formed, and you may worsen bleeding. So don't resuscitate on your way to the operating room when you're going to get definitive control. Don't resuscitate to normal blood pressures. Resuscitate to a palpable pulse and normal mentation. So as long as they're conscious and you can feel a pulse, that's adequate to get you to the operating theater. Once you've got definitive control of their bleeding, then you can shoot for normal blood pressures. But this concept of permissive hypotension has actually been shown to be superior to shooting for normal blood pressures in before you have control. Another way to get control is tourniquet. This is very effective on extremity bleeding. I will say it's effective when used properly. So it's useful to have some training in tourniquets before you have to use it for the first time. If you have a prefabricated tourniquet, they work great. If you need to improvise a tourniquet, that's okay. You can improvise tourniquets also work. If you have put a tourniquet on and the patient is still bleeding from their leg or their arm, put a second tourniquet above that first one and tighten it down even tighter. So I've had to do 2 tourniquets before, and sometimes when one doesn't work, 2 does. I said it's useful, very effective when used properly. The thing that I've seen that is the failure of some of these tourniquets is when the provider doesn't tighten the tourniquet down tight enough. You can imagine the scenario where a patient is bleeding into the leg. You put a tourniquet on and you only tighten it so much that you overcome venous pressure, but not arterial pressure. And when you don't do that, then blood is still going into the extremity, but now can't come back out. So you're potentially worsening that problem because now you're having all the blood get into the leg, continue to bleed, and not get out of the leg. So you have to tighten that tourniquet tight enough to cut off arterial blood supply. If the injury is to an artery. We always get asked, how long can I leave the tourniquet on? Well, the shorter answer is you leave it on as long as you need to, as long as it takes to get definitive control, because you're treating the life over the limb. And just know that limb salvage does go down over time, so it's useful to keep track of when the tourniquet was placed. Kind of goes down linearly over time. We have good experience in the military that, up to 6 hours, patients have pretty good rates of saving the extremity with a tourniquet on. After that, it does start to go down a little faster. So just keep that in mind. I mentioned the lethal triad: hypothermia, coagulopathy, acidosis. I think this is a key concept in that vicious cycle. So the ways we combat it, patients are cold, warm up the room. Get the room as hot as you can. Warm up the patient. Take off the cold or wet clothes, put on warm blankets. If you have a forced air rewarmer, like a blowing warm air, do that. And warm every fluid that goes into the patient. So you're giving them blood, warm up that blood before it goes in. If you have a fancy blood warmer, great. If you just have a bucket of warm water that you can put the blood into before it goes into the patient, great. Like put the bag of blood into. I've seen medics who will hold the blood in their armpits or in their groins to keep it warm before they have to transfuse it to the patient. The way you combat the coagulopathy is giving a balanced ratio. I'll talk a lot more about that here in a second, but essentially you want to reapproximate whole blood as much as possible. Not just giving packed red blood cells, but also giving the FFP, the plasma and the platelets that are going to allow the blood to actually clot. And then acidosis is recognizing that and making sure that you're resuscitating the patient adequately. So keep in mind that lethal triad. There's the concept of damage control surgery is kind of beyond the scope of this talk, but when I'm trying to decide in the operating room, am I going to keep a patient with an open abdomen and just put packs inside to stop the bleeding temporarily, then get them to the ICU, resuscitate them, and then bring them back? The thing that's going to make that decision for me is, are they already in this lethal triad? If I talk to the anesthesia provider and they tell me the patient's cold and their pH is low, I'm going to go into damage control mode. If they're doing great, then I'm going to finish the operation. But I use this on a daily basis in making decisions about patients. I said I would talk more about blood transfusion, so here we go. Hemorrhagic shock. We've done a lot of research recently on the best way to transfuse, the best way to give patients who are in shock fluids back. First thing that we learned is that blood is better than crystalloid. For years, we taught give patients 1 liter or 2 liters of lactated ringers or normal saline before starting blood. That's probably bad advice. In a pinch, if that's all you have, you can give some crystalloid, but the patients are bleeding blood, and the thing that you need to give back is blood, not salt water. So if you have whole blood, that's the best thing you can give a patient. Blood that has not been fractionated into packed red blood cells and plasma and platelets. If you have whole blood as a product, give that. If you don't have whole blood, then give what we call high ratio transfusion. So for every unit of packed red blood cells, you're giving a unit of plasma and a unit of platelets. Warm the blood if possible, as I mentioned. And then calcium is often overlooked and should not be when you're doing massive transfusion in shock. Blood that's stored, they give citrate in the bag to help prevent that blood from clotting in the bag. That will lower your body's calcium when it's transfused. So as soon as I'm starting to give multiple units of blood, I'm giving calcium. I give it empirically before I even get a lab value back. Because if you wait for the lab value to come back, you're going to be way behind, and that's going to cause worsening of your shock. Low hypocalcemia will. So whole blood, like I said, it's got all the components: packed red blood cells, plasma, platelets. So it's the gold standard transfusion fluid in trauma. If it's fresh, meaning it hasn't been stored on the shelf or in the refrigerator for a long time, that's better. We know that as you store blood, the enzymes degrade, the platelets start to die. So the longer it's been on the shelf, the worse. So fresh blood is the best blood. It gives you improved hemostasis, and it's been shown in multiple studies now in the military and in the civilian world to improve survival in trauma. The U.S. military, I don't know about if you guys are doing this in Ukraine yet, but uses the walking blood bank. So every soldier that's deployed is pre-screened for viruses and has their blood type already known, so that when trauma patients are coming into a hospital in that they will announce over the speaker that patients are coming in, and the soldiers will line up and they'll give a unit of blood, so that blood can be taken as fresh whole blood and immediately transfused into a trauma victim. High ratio, I've said this and I'll say it one more time. We try to do 1 to 1 to 1. When I say 1 to 1 to 1, that's for every unit of packed red blood cells, it's a unit of FFP and a unit of platelets. We know from studies that 1 to 1 to 1 is the best, although if 2 to 1 is almost as good. So for every 2 units of packed red blood cells, at least give 1 unit of FFP. So try to get to as close as you can to 1 to 1 to 1. If you're 2 to 1, that's adequate. I wouldn't get lower than that. It's not for free, though. Giving all this blood product, all this immunogenically active blood product, all this fluid to a patient has consequences. 3 of the common ones that we see are transfusion-related acute lung injury, or TRALI, transfusion-associated circulatory overload, or TACO, and then increased risk of infectious complications. Every time you give a unit of blood, it's causing some immune dysfunction in the host, in the patient. So we do see higher risk, higher chances of things like pneumonias, etc. So just a word on TRALI. This is a non-cardiogenic acute respiratory distress syndrome. It occurs within the first few hours of giving large amounts of blood. And it's because of the donor plasma reacting with the recipient's white blood cells. You get an activation of the inflammatory cascade, and then you get essentially a respiratory distress syndrome in that patient. You're going to see a chest x-ray that looks like this, bilateral fluffy infiltrates. And there's not a whole lot you can do other than supportive care. So good ICU care is the way you allow that inflammatory cascade to run its course, and then the patient will start to heal. TACO, similar. It's just the consequences of giving a ton of fluid to somebody. You get pulmonary edema, you get heart failure, and it's going to present just kind of like circulatory collapse and volume overload. And the treatment for this is, as soon as you can restrict those fluids, stop. Once the patient can tolerate diuresis, do that, and then support them as their body heals from this. Just one last topic on blood transfusions is how to actually do it. So I said give patients high ratio, give whole blood, or 1 to 1 to 1. It's useful to have a protocol in your institution on how to actually accomplish this. So we have at all the major trauma centers, we have a protocol, a massive transfusion protocol. And this is just a standardized way of getting the blood from the blood bank to the patient. You have an activation criteria and then an actual products that the blood bank dispenses. And it's just a way of getting all those blood products to a patient rapidly. If it needs to be activated, activate it early. And you have to have some criteria for who to give it to. But these are usually patients in extremis, so patients who are in shock from hemorrhage. This is just a picture of a military one. It just describes their massive transfusion protocol. Pack 1, or the first cooler that comes, they'll have this. Pack 2 will have this, 3, 4. So each time the blood bank sends a cooler off, they're starting to prepare the next cooler so that you can rotate those through and have continuous blood getting to your patients. So it's useful to have a protocol. And then kind of related to blood transfusion, but not a blood product per se, is this issue of tranexamic acid. This is a product that prevents hyperfibrinolysis, so clot breakdown, which can sometimes happen in trauma patients. It's a little bit controversial because we don't know how helpful it is. We don't think that it's very harmful. The side effect profile seems to be small. Whether or not it helps is a little bit of an issue of debate. What we do think that there is evidence from pretty large trials that there is some small amount of survival if you give it to a ton of patients. What we do see is that if you're going to give it early. So in the first 3 hours after an injury is when to give the TXA, tranexamic acid. So that's hemorrhagic shock. Remember, trauma victims, causes of shock and trauma. It's hemorrhage, it's hemorrhage, it's hemorrhage. Once you've kind of ruled out those things, then you can start to think about the less common things in trauma, especially obstructive shock. You want to figure that out pretty quick. Neurogenic shock, you have a little bit of time to figure that one out. And then if a patient's delayed, they can get septic shock. And if they're a burn patient, they can get non-hemorrhagic hypovolemic shock. So let's talk about those real quickly. So hypovolemic, but non-hemorrhagic, so burn patients, the special population, we see it commonly associated with trauma. And so it's worth mentioning a little bit about it. The key here is aggressive and early fluid resuscitation. Burn victims often have inhalation injuries and can have swelling of their oropharynx and upper airway. So if they need intubation, intubate them early. As you give them tons of aggressive fluid resuscitation, that airway is going to swell worse. So take the airway early in burn patients. As their airway swells, so is the rest of their body going to swell. So if you see the patient starting to swell and you're worried about compartment syndrome, either in the extremities or the trunk, escharotomy is the name of the game there. That's how you treat that. Do an escharotomy early if you're concerned. Early burn excision. So early for burns is after that initial resuscitation phase. So usually a big burn comes in. First 24 to 48 hours are resuscitation, giving them fluids and stabilizing them. And then after that, you take them to the operating room and cut away, excise that burn eschar. Because after a couple of days, that burned tissue just becomes a massive inflammatory process on the patient. It has to be removed in order to save that patient. And we usually use topical antimicrobials like silver products to dress the patient. So the first thing you want to do is figure out how much the patient is burned. There's a lot of different ways to do this. The rule of nines is pretty common. There's a chart on the right that shows the rule of nines. Every different kind of part of the body has some sort of fraction of 9 associated with it. A patient's palm is about 1%, if you want to use that to estimate. And then there's these Lund-Browder charts, or another way. They are a little bit more detailed than the rule of nines and give you a little bit more of an exact number. When you're adding up the percentages, remember only second and third degree burns count. First degree burns don't count towards your total body surface area burned. And usually we start to get worried and start to put patients in the intensive care unit and start that large volume resuscitation at about 20%. That's when all this kicks in. So how much fluid do you give a burn patient? Lots of different formulas, lots of different ways to do it. Parkland formula is the kind of gold standard. It's the one that's been used the longest. That's for every, you give 4 mLs of fluid for every kilogram for every percent total body surface area burned. And that's like the total volume you're going to give in 24 hours. You give the first half of that in the first 8. And over the next 9 to 24 hours, you give the second half. And you calculate that from the time of injury Just know that patients who are delayed presentation and have inhalation injuries need a slightly higher volume than that. The key to all of these formulas is adjust frequently. So you start off at some sort of fluid rate, but then you want to quickly adjust that based on your endpoints of resuscitation, like urine output. Parkland has been around for a long time. It's the original formula, but other formulas have now been starting to get more traction. There's the modified Parkland, which is 2 to 4 mLs of fluid. That one's probably a little bit closer to what's a patient actually needs. And then the military has a very simple way of doing it. You just do 10 mLs per hour for times the body surface area. So if they're got a 30% burn, you're starting their fluid rate at 300 per hour. 40% burn, 400 an hour. And then if the patient's really heavy, you're going to add another 100 for every 10 kilograms above 80 kilograms. And once you're getting to crazy high rates of fluid, that's when you start to reach for the albumin as well, if you have that available. But like I said, adjusting is the name of the game here. So you start at some fluid rate based on your calculations, but then you want to adjust. So get that Foley catheter in the bladder and start measuring the urine output immediately. And you want to shoot for 0.5 to 1 ml per kilogram per hour. If they're way over that, you turn the fluids down. If they're way under that, you turn the fluids up. So every hour you're making an evaluation and adjustment of the fluid infusion rate based on things like urine output. Urine output isn't the only one. We'll talk about the ways to assess perfusion, but it's the most common way in burn victims. And avoid boluses in burn. Just a side note, avoid boluses in burn patients. Everybody else, we like boluses, but in burns, they have such an inflammatory, they're so leaky that if you give them a bolus, so much of that fluid is going to go immediately into the third space. That it's, in burn patients, as a unique subset of patients, it's helpful for them to just adjust hourly rates of infusion. I mentioned escharotomies. So any circumferential deep burn, so circumferential around the arm, circumferential around the chest, that's when you need to think about escharotomy. If it's circumferential and deep, like this picture, that's almost certainly going to need an escharotomy as the patient starts to swell, so do it early. I recommend using electrocautery, a bovie, because the skin bleeds more than you think it will when you're cutting into the skin. And only make those skin through the eschar. You can't do an escharotomy through normal skin. So if you want to know how far to cut all the way the length of the eschar. You can see kind of the classic H shape on the chest. So that's releasing both lateral aspects and then also separating the abdomen from the chest. That's a classic H, or a box. You can see that they went and did another crossing escharotomy superiorly. You can also do this on the arms. Unlike fasciotomies, there's no you'll see pictures of recommended places to do it, but escharotomy, it's really just releasing that circumferential band that's around the extremity. So you don't have to do it in any special place. Any location on that extremity will work. You just need to break the circumferential part up. Last thing about burns is how likely is the burn patient to survive? No exact science there, no great way to know. There is this revised Bow score. It's a nomogram, so you actually have to kind of come up here and figure out the patient's age. So if they're 70 years old and they don't have an inhalation injury, you're going to go to the second column and you're going to go through the percentage. So if they're 70 years old and they're 50% burn, you keep drawing this line and it gets down to here, they're going to be a 70% chance that they're going to die. So, and you can look if they do have an inhalation injury and they're 70% burned. Well, now you're looking at 97% chance they're going to die. So this Bow score gives you a good estimate of, or a reasonable estimate of mortality chances. So you know from the beginning how much trouble you're in. So that's it for hypovolemic. That's kind of the main part of this talk. I'll very quickly go through the other types just for completeness sake. Distributive shock, that's septic, neurogenic, anaphylactic. Again, this distributive shock, low blood pressure, increased cardiac output actually, or normal. You're low SVR because you're losing that tone, and low volume. So to start off with, septic. So this is a very common problem. You got to be early and aggressive with your treatment. You're going to diagnose it by figuring out that they have an infection and they have shock. That's patient in septic shock. So the mainstay of this is starting antibiotics immediately. Start them broad and then narrow based on your culture data. Get those cultures if you can. Give them crystalloid. We've gone back and forth as to how much crystalloid, but what we're settling on now is give a bolus up front of 30 mLs per kilogram. And then you adjust how much fluid you give them based, again, on patient physiology, things like urine output. Get source control. So if they've got an abscess, drain it. If they have a necrotizing soft tissue infection, cut it out. But start these antibiotics immediately and then get source control. You're not going to solve the infection until you've got control of the source. And then if you've given enough fluid and they're still hypotensive, then you move on. You don't continue to flood them with fluid, but you start some of these vasopressors. Levophed or norepinephrine is the first line for sure in shock. Second line is vasopressin to keep the MAP above 65. That's your goal usually in sepsis. I'm not going to spend a lot of time talking about vasopressors and ionotropes, but in any discussion of ICU care and of shock, it's useful to have some knowledge of these so you can pick the right one. But these are the ones that we commonly use here in the United States: phenylephrine, vasopressin, norepinephrine, epinephrine, dopamine, less commonly used now, dobutamine, isoproterenol, and milrinone. I would say those are the most common pressors we see. And I'll talk a little bit about which ones to use in which situation. But again, in sepsis, norepinephrine and vasopressin are our top two choices. And I've alluded to the endpoints of resuscitation. How do you know if you've given enough fluid? I've alluded to this a couple of times, and I've said urine output. That's all we've talked about so far. But know that there's a lot of different ways to answer this question. Have we given this patient enough fluid? Because it's not an easy one to know. So urine outputs is a common one, but we also look at heart rate, blood pressure. You can raise the patient's legs up and see if their blood pressure goes up. That's kind of an auto transfusion. You can take an ultrasound and look at their IVC, their inferior vena cava. If it collapses with inspiration, then that's a patient who needs more volume. Pulse pressure variation, like you can see on this monitor, if the blood pressure drops every time they take a breath in, that's a patient who needs more fluid. You can look at central venous pressure. This is really only helpful at the extreme, so really high or really low can give you information. Lab values, so base deficit and lactate are other things that we use. Or when in doubt, just give the patient fluid and see if the blood pressure goes up. And if they respond, then you know that they need more fluid. If they don't respond, then maybe they've got enough already and there's something else that's causing the hypotension. So that's it for sepsis. Neurogenic, we do see this in trauma, usually spinal cord injury. That's the most common cause. All these neurogenic, whatever the cause is, it leads to loss of vascular tone and vasodilation. So the treatment of that is to kind of fill that increased vascular space with more fluid and then add some sort of tone back with vasopressors like phenylephrine or norepinephrine to help squeeze the peripheral vascular system back down to a normal space. Spinal shock, just know that if you heard the term spinal shock, that's not the same as neurogenic. Spinal shock is kind of not really shock. It's just the description of loss of motor and sensation function below the level of the injury. Just a definitional issue there. Don't be confused by it. Finally, anaphylactic. This is just a really severe allergic reaction that leads to vasodilation. So if you see a patient who's been exposed to something that they're allergic to and they've got a rash everywhere and they got angioedema, so really swollen face, that's when you're reaching for a different pressor, epinephrine. That's for sure the first line treatment in anaphylactic shock. Then you're giving the patient fluids and steroids and antihistamines. Obstructive. This one is a few kind of specific scenarios. Tension pneumothorax. This is the air leaking into through an injury in the lung into the pleural space and causing compression. You can see in this picture here, this is the lung, and all this space is empty space filled with air. And as you can see, this air is now under pressure because it's starting to shift the entire mediastinum into the left chest. This is tension pneumothorax. So you see this patient without any breath sounds on one side, their trachea is being pushed to the opposite side, their blood pressure and their oxygen saturation are falling. This is a patient who needs immediate needle decompression followed by a chest tube or straight to chest tube. Cardiac tamponade. Commonly see this in trauma, but also in pericarditis, uremia, cancer, infections can always cause fluid around the heart. You're diagnosing this with an ultrasound. You put that ultrasound probe in the chest, that fast, and you can see this fluid. This is this dark stripe outside of the heart. That's fluid around the heart. That causes constriction of the heart's ability to pump. and that needs to be addressed. If it's one of these more chronic conditions, you can do pericardiocentesis, where you, under ultrasound guidance, put a needle into that space and drain it out. In trauma, this doesn't work so well. Usually the volume in trauma is smaller because it's very acute, so it's harder to hit. The blood starts to coagulate, so it's harder to drain, and you still got a hole in the heart, so it's harder for that to stop with just a pericardiocentesis. So in trauma, and these other things you can do a pericardiocentesis, in trauma, do a sternotomy. Open the chest, do a thoracotomy. Open the chest, evacuate the blood, and fix the hole in the heart. Massive PE, this is diagnosed with a CT scan. Here you can see this is contrast in the pulmonary artery. You can see a giant clot here on this side and also on this side. That is the most common way to diagnose this, is with a CT scan of the chest. And then for smaller PEs, you're just going to put them on anticoagulation, like a heparin drip. For these large ones, you're talking about clot lysis, either with something like TPA or a catheter-directed thrombolytics, or even surgery to remove the clot. Final thing in obstructive is abdominal compartment syndrome. Any patient who's gotten massive transfusion can have so much pressure build up in their abdomen that they compress the IVC and inhibit organ perfusion. So in any patient who's swelling massively, you see the abdomen getting huge, check a bladder pressure. If their bladder pressure is high, so above 20, and they have something like low urine output or high peak pressures on the ventilator, this patient needs to have their abdominal compartment syndrome addressed immediately. You can put a rectal tube and a gastric tube in, and you can paralyze the patient, and you can do a paracentesis to try and draw off some fluid, but these are all temporizing measures. What their patient really needs is a laparotomy to decompress. Here's what happens to an abdomen that's under pressure when you open it. Everything starts to eviscerate. So that's a patient with abdominal compartment syndrome. Last type of shock, cardiogenic. This is just problems with the heart. So this is a patient going to have low heart rate, low MAP, low cardiac output. They're going to be squeezing their peripheral vascular system to try and help. That often makes the heart function worse, and they are going to have normal or even elevated volume. So you're going to diagnose this with your exam, your labs, your echo of the heart. That's probably the most common way, or even taking the patient to the cath lab. And unlike when you grab the feet of somebody in shock, septic shock is going to be warm, right? Because or distributive, because it's all that blood flow is going to the extremities because it's dilation. When you're clamped down in cardiogenic shock, you put your hands on their feet, it's going to be cold. So that's a very quick way of distinguishing between those two at the bedside. So how do you fix it? You got to fix the heart. So you got to improve the cardiac function. So reducing that afterload, if that means giving some vasodilators, so pressors that vasodilate or reduce afterload, like dobutamine or milrinone, things that help the heart squeeze, like epinephrine. Optimize their preload. Sometimes that means taking off fluid, so giving diuretics. There's mechanical support devices. That's when you're getting into fancy cardiac surgery. Your balloon pumps, your ventricular assist devices, your ECMO, and then fix the underlying cause. That often means reperfusing the heart, fixing a valve or an arrhythmia. Last slide before we get to questions. When all else fails, you've treated all these things and the patient's still hypotensive and you can't figure out why. Sometimes this can be due to adrenal insufficiency. It's not super common, but we do see it. So if you have refractory shock that's just not getting better despite your best efforts, we don't even test for this anymore. We just treat empirically if we are at this last line of trying to figure things out and the patient's still hypotensive. Give stress dose steroids and see if that helps. And of course, if you're reaching for the stress dose steroids, then you're kind of in a place where you don't know what's going on. So it's always good to reevaluate their volume and put an ultrasound probe back on their heart to look at their cardiac function. So that's it. The shock is inadequate tissue perfusion. Remember that it's not just low blood pressure, it's inadequate perfusion of the tissue. So you have to see end organ damage. You got to figure this out quick. Time is tissue. Treat immediately at the same time you're doing your diagnostic maneuvers. 4 big categories: hypovolemic, cardiogenic, obstructive, distributive. And then in trauma, because I'm a trauma surgeon, so I'm gonna foot stomp this one. In a trauma patient, shock is hemorrhagic until proven otherwise. Thank you very much. We can get to questions.
Героям слава. Thank you very much, Dr. Anderson, for this wonderful lecture. Very high yield topic for nowadays realities in Ukraine. And we have already several questions. First from Dr. Nozrin, please.
Good evening. Thanks for beautiful talk. I just meaning to ask, let's say we have a patient with 2 or 3 liters of blood. He has a hemorrhagic hypovolemic shock. How do I know how much packs of blood do I need to give him? Or it's like, if estimated blood loss is 2 liters, so I need to give the same amount of packs of blood, or I need to check all of that resuscitation parameters like urine output and etc.
Yeah, great question. How much to give is always tricky. It's always difficult to figure that out. It's honestly the biggest source of research in critical care, and we don't have a great answer yet, which is why on that one slide I had a list of like 7 physiologic parameters to check. None of them are great, but that is the best we have. So use all of those in concert, in combination, to give you an answer. You don't have to give all the fluid back that they lost. If you saw in that chart, you can lose 750 mLs of blood and not that. So that's, 2 full units, and you don't even have any physiologic consequences of it. So you don't need to give them everything back, but you need to give enough where you start to have, you're perfusing, you're getting out of shock. And your evidence that you're perfusing organs is they're making urine, their lactate is clearing, their mental status is improving. All these things are getting better because the organs are being perfused. So that's your goal, not getting to physiologically totally normal, but getting to enough where organs are being perfused and then allowing the body to heal. Oftentimes, if we overshoot, then you get into other problems of volume overload that need to be dealt with later on. Because the patient's physiology is disrupted. Oftentimes the capillaries are leaky in this state. And so if you overshoot, not all of that stays within the circulatory system. So that fluid has to be dealt with at some point. Great question.
Thank you, Dr. Anderson. Next question from Dr. Boyarsky, please.
Thank you very much for the lecture. My question about what fluids should be used in patients with burns?
Yeah. So in burns, they're not generally losing blood. Now, they will lose blood when you start to do your escharotomy or your excision of the burn. So when you actually when you're actually in the operating room and you're cutting away the eschar, cutting away the burn tissue, they're going to bleed a lot, and then you can give them blood back. But in that initial resuscitation phase, when you're doing just giving them fluid back, they're not bleeding, but they are weeping fluid. They're weeping the body's fluid, the serosanguinous fluid everywhere. And so you need to give them, we give them crystalloid back. And I tried, it's going to be large volumes of crystalloid. So I try to avoid normal saline because then they're going to get hyperchloremic and acidotic from that. So we usually use something like Ringer's lactate or Hartmann solution or Plasmolite, some sort of more balanced, less chloride heavy crystalloid.
Thank you, Dr. Anderson. Next question from Dr. Smirnova, please.
Thank you very much for your lecture. My question is it common in your practice to use a Reboa catheter for patients with hemorrhagic shock? And what is the maximum time of using this method? I mean, for example, if we locate this catheter near the bifurcation of aorta.
Yeah, Reboa is a hugely controversial topic in trauma right now, and no one knows the answer to that. What I've seen, I have used Reboa several times, and my enthusiasm for the technology has gone down a little bit over time, because what a Reboa is, it's a cross clamp on the aorta. So it will raise your blood pressure, and when you put the balloon up, it's great. Like somebody goes from almost coding to wow, their blood pressure becomes normal again, and everybody then kind of everybody in the room kind of relaxes. But that is the exact wrong thing to do. Because you have to say, no, their blood pressure looks good because I have clamped the aorta. We need to run like our hair is on fire to the operating room to get control of the bleeding. Because the longer that clamp, the longer that balloon stays inflated, the worse the physiologic consequences are going to be. So I've left it up for as short as 20 minutes. And even after 20 minutes, when I let it down, the patient went into DIC, and we had horrible physiologic consequences from that. So it is better than letting the patient die, but just know that it has a major physiologic consequence to blowing up that balloon. There are some ways of mitigating that. You can do something called partial Reboa, where you don't blow up the balloon all the way, but you inflate it just enough to get your blood pressure to perfusing levels, where the patient's now maintaining and has a palpable pulse. And with that, you get the patient to the operating room, you do your laparotomy, you do your thoracotomy, you get control of the bleeding, and then you take down the the balloon as rapidly as you can. So Reboa has a place. I don't think we fully define exactly when or where to do it, but just know that it's not a panacea. It does have real consequences. And if you blow up that balloon, you need to move quickly to source control of the bleeding.
Thank
Thank you
you.
very much.
Thank you, Dr. Anderson. And we also you also answered the question on the chat about the Reboa. So thank you. And next question from Dr. Hassan El Kafarna, please.
Thank you, Doctor, for the great lecture. My question is about the resuscitative thoracotomy and what are the indications for that?
Yeah, good question. Resuscitative thoracotomy. So, you know, indications for resuscitative thoracotomy, I'm doing it in any patient who's lost pulses, so has had a cardiac arrest from trauma. And then how long am I gonna, like, how long can they be dead before I think it's futile? I think you're gonna get different answers. And honestly, I think the answer is a little bit different based on how physiologically fit the patient is preoperatively. If the patient's 80 years old, I'm really not going to do a resuscitative thoracotomy. If they're 20, I'm going to do it even if they've been down for some period of time. There's studies, and so there's good evidence that if the patient comes in and you put an ultrasound and they're in cardiac arrest, you put an ultrasound probe on their chest, if there's zero cardiac activity, there's no cardiac activity at all, the chances of a resuscitative thoracotomy being successful are near zero. So that is one way of kind of triaging to yes to do it or no, a quick ultrasound probe on the chest. You should know that the patients who have the best chance of survival, penetrating trauma, so a patient who's been shot or stabbed, and thoracic trauma. So if they've been shot or stabbed in the chest, those patients have like a 20% survival chance. So those patients, I'm for sure doing it. Now, again, I haven't answered your question directly as to how long. If they lose their pulses in front of me, they lose their pulses in the ambulance on the way to the hospital, I'll usually do it. If it's the ambulance crew found them without a pulse and then put them in the ambulance to come to the hospital, I'd be hard pressed to do it. Because your chances, they just go, it goes down linearly over time. So the longer that's been down, the worse your chances. But again, the patients who are going to make it are penetrating injury, chest trauma, young patient, short downtime.
Thank you, Dr. Anderson. Next question from Dr. Chervonochenko, please.
Dr. Anderson, thank you for a lecture. Could you please give some advice on how to manage a patient who needs aggressive fluid resuscitation and has a known history of severe congestive heart failure to not overload the patient?
Oh, you're in trouble with that one. That's just a near impossible scenario. So essentially what you need to do is give the exact right amount of fluid. You're on a razor's edge right there. I would resuscitate them with fluid, like septic shock, for instance, give that initial bolus, but very rapidly reach for those pressors. And usually that there's a resuscitation phase. So in the first 24 hours or so, I'm giving them fluid, but I know that pretty darn quickly, I'm going to have to take that fluid away. So if they do actually need their volume down, but also have a really bad heart, I'm reaching for all the adjuncts that I can to try to figure out how much fluid that I'm going to give them. So that's a patient who I am putting an ultrasound in their heart very frequently. I might even put a pulmonary artery catheter. I'm not a big fan of pulmonary artery catheters, of Swan-Ganz catheters, but that's the exact patient who would need one because they have a mixed shock, a cardiogenic and a hypovolemic shock. So I'm using every piece of data that I can to give them just the right amount of fluid, knowing that in the first 24 hours, I'm probably going to overshoot a little bit on the fluid resuscitation. And then pretty darn quickly, I'm going to have to start taking that fluid away. So that scenario you mentioned is just one of the most difficult in intensive care. It is balancing on that knife's edge and between too much and too little fluid. Because someone's heart who's not going to take it is just not going to take it. Now you can use those pressors that I mentioned to kind of help you, help support cardiac function. So if the patient has a bad heart, I'm going to reach for those pressors early, and I'm going to support their heart with some extra squeeze from those pressors. But don't do that immediately before you've reestablished some volume. So use all the data you have, use extra data, and just be very, very careful. That patient needs to be reassessed very frequently. And if they go into renal failure, then you're in an impossible situation.
Thank you, Dr. Anderson. Next question from Dr. Miroslav Ligun, please.
Thank you for a great talk. My question is about tourniquet. Is it a good idea to reduce pressure of the tourniquet on the limb and start that bleeding again and provide some blood supply? Can it help us to increase the time of transplantation to a hospital?
Yeah, that's a controversial topic. I would say, and as a general rule, no. I think that the only person who should take down the tourniquet is the person who can deal with the bleeding ultimately. So you run into the risk of unleashing bleeding that you can't stop if you try to take the tourniquet down. So my advice is to keep the tourniquet up until you get to a place where you can deal with the bleeding.
Thank you. Question from Dr. Stanislav Smolar, please.
Good evening. Thank you for the great lecture. My question is not directly connected with our topic, but how do you manage acute hemorrhage from spongy bones tissue with bone marrow?
Yeah, that's always hard, right? You know, that one is, you're using, again, every trick in the book that you have. You're reducing the fracture as best you can. You're reapproximating the bone. Often that pressure from the bone reapproximation will stop the hemorrhage. You're fixating the bone in some way that you can, either externally or internally. You're using things like bone wax, so sometimes can be helpful. Electrocautery is not often effective, but you can try that. And then if you have any hemostatic agents, powders and gels and stuff that have hemostatic function, then those are nice adjuncts. Not a real great way. I don't have any panacea for you. I don't have any like magic way to deal with that, but just your normal principles of reducing the fracture, fixating the fracture, using some bone wax or some hemorrhagic agents, hemostatic agents. Yeah.
Thank you. Next question from Dr. Georgi Ismailov.
Hello, thank you for the great lecture. My question is about hemotransfusion. So in your hospital, let's imagine we have a patient with first-degree hemorrhagic shock. Do you always transfuse blood products, or you can just let him be like on colloids and crystalloids, given that he has lost about like 500 mL of blood?
Yeah, if a patient, good question. If a patient is bleeding but has not had any physiologic consequences of that, I won't give them any fluids at all. I won't give them blood because they'll get the negative consequences of blood without the positive effects of it. I actually won't even give them crystalloid either, because I risk diluting the clotting factors that the patient's going to need to continue to form that clot to stop the bleeding. So I will keep that patient off of all fluids, actually.
Thank you, Dr. Anderson. And one of the lastest questions from Dr. Sofia Lisecka.
Good evening. Thank you so much for a great talk. And my question is, what do you think about early fasciotomy in patients with extremity injuries, especially low extremities? Should we wait or just do it as soon as possible?
Yeah, great question.
Or when we only suspect the compartment syndrome? Yeah,
when to do the fasciotomy? That's a great question. In the military situation, we did them very early and very often. Often because you would have multiple patients at a time and you had reduced ability to keep an eye on that extremity, and we had long transport times. So we would put a patient in an ambulance or a helicopter and send them away for hours. If you have either of those scenarios where you've got a lot of patients and so you can't monitor that compartment very frequently, or you have to transport the patient where it's not safe to do a fasciotomy in the back of a helicopter or something like that, then I would just prophylactically do the fasciotomy. Outside of that kind of scenario, I think that you can be more selective in when you use them, and that's when you suspect that the patient either has compartment syndrome or is almost certainly going to develop it. Patients who are have it, you're looking for your normal diagnostic criteria for compartment syndrome. You can measure compartment pressure directly if you have the device to do that. I do recommend measuring compartment pressures. I think it is useful. I find that a lot of the patients who develop compartment syndrome, we talk about, doing it's a clinical diagnosis, but a lot of the patients are unavaluable, right? Like the patients who are at risk for having a compartment syndrome are also the ones that you can't ask if they have a lot of pain. So I do actually measure compartment syndromes quite liberally, compartment pressures quite liberally. And then who to do it on, the patients who are classically at risk for it, anybody's going to get massive resuscitation. So burn victims, massive transfusion, patients who've had ischemia to that limb. Patients who have had, have a vascular injury to a leg and have some sort of delay. So their lack of perfusion of that leg they've had a tourniquet or an arterial injury for 3, 4, 5, 6 hours. Those patients are at high risk. And anybody who has a combination arterial vascular injury. So they both have a problem with inflow and outflow from that extremity. Their femoral artery and vein are injured, both. Those patients are at high risk for compartment syndrome, and I have a lower threshold for doing it. But do it early because it is devastating, the consequences.
Thank you, Dr. Anderson. We have one question from Dr. Kalpak. Anton, please.
Thank you for your lecture. My question is, do you use extra clotting factors, I mean, fibrinogen or something like that in treatment for patients with hemorrhagic shock? Thank you.
Yes, I do. I start with the high ratio transfusion, as I mentioned, the packed red blood cells, the FFP, the plasma, the platelets, or whole blood, if I have that product available to me. Pretty soon after you get the labs start to come back, or even if I'm giving just massive amounts of those products, yeah, I'll reach for something like cryoprecipitate because it's going to have a concentrated amount of those factors in it. I don't use factor 7, for instance, but cryo is one that we use commonly. And then certainly if a patient has some sort of clotting disorder, so they've taken Coumadin or they've taken some other procoagulant, they take some sort of anticoagulant at baseline, then some sort of reversal agent, whether that's giving plasma or giving a prothrombin complex concentrate or another reversal agent is another reason to do it. But oftentimes you'll find that patients who are getting large volume blood product resuscitation will need something in addition, like fibrinogen, cryoprecipitate, something like that. So I'm measuring those lab values too to help guide that. There's also something called TEG, thrombin elastogram. So these are more kind of real-time measures of coagulopathy. They're not available everywhere. We're just getting it at our institution, but the institution I was at before had it, and we would use that to guide what products we're giving, because you can in real time see what part of the coagulation cascade is being affected. And then oh, I need to give this patient TXA. I know I need to give this patient fibrinogen. So that can help guide you, something like TEG as well.
Thank you, Dr. Anderson. We have two interesting questions on the chat from Dr. Nozdrin. Are you starting blood transfusion after definitive surgery, bleeding control, or as soon as possible?
As soon as possible. As soon as possible. Again, not shooting for normal blood pressure, but just enough to keep the patient conscious and with a palpable pulse as I'm rolling that patient to the operating theater to get definitive control. But I'm starting right away.
Thank you. And from Dr. Smolar, the question is, in patient with hemothorax, how much blood should we get to understand we should perform thoracotomy?
Yeah, good question. There's not a great answer to that question. The textbook will tell you something like about 1.5 liters immediately, or 200 mLs of fluid every hour consecutively for about 3 hours. Just know that that's not based on literature. That's just Dr. Maddox from Texas, what he thought was a good number. Now he's like one of the most experienced trauma surgeons in the world, so he's probably right. But just know that that's not based on data. That's just one surgeon's gestalt. But anecdotally, he's probably about right. When you have that much blood loss, that's probably more than you're going to be able to deal with just by transfusing a patient through that. That represents ongoing massive hemorrhage that needs to be surgically controlled. It's not very common. About 80 to 90% of thoracic injuries can be managed with just a chest tube, but it does happen when you get that massive hemorrhage that patient needs to go for surgical control.
Thank you, Dr. Anderson. And we have the last question from Victor Chervanochenko, please.
Dr. Anderson, could you please tell if we have a patient who needs hemotransfusion, but we don't have a right blood group matching the patient? Can we give the patient an O negative blood? And if we do so, and if we do so, and the patient has some complications, and maybe even leading to devastating morbidity or even death of the patient, can it be considered as a malpractice?
So the answer is yes. I'm almost always starting uncross-matched blood initially in the trauma bay. Because we don't know what the blood type is yet, and I'm not going to wait for that to come back, or the blood type or the cross match to come back. But I am sending that off in my initial set of labs, so that as soon as I do have that data, I'm switching from uncross matched blood, so O negative, O positive blood, over to a type specific blood. So as soon as I can make that transition, I will, but I'm not waiting for that data to start my transfusion. So for packed red blood cells, you can give the O. For plasma, you got to get the opposite. You got to give the AB. As the universal donors. But as soon as you have some more data, the blood bank will be very happy with you if you switch over to the cross match, the specific crossed and typed blood. And your question about malpractice, no, I would say that's standard of care to do that. So that's not in any way malpractice.
Thank you very much, Dr. Anderson, for this wonderful lecture, for answering questions, and for giving us extra time with these questions and answers. Really a very important topic for Ukraine and generally. And we all enjoyed your presentation. So thank you very much for joining us today.
Thank you all. I enjoyed it. Good questions.
Thank you.
Thank you.
Thank you, doctor.
Much.
Thank you.
Thank you.
Bye.
Thank you.